everybody. Welcome back to the Superior Health Quality Alliance series, supporting residents in skilled nursing facilities with opioid use disorder. This is the last and final of our series, and these are all recorded and on our Superior Health website for your viewing. But this is session 4, and today we're actually going to be discussing opioid use disorder, a more of a patient-centered approach for long-term care. So just a couple things before we get started, some housekeeping items. Mute your line to avoid any background noise. And then if you have any comments or questions, feel free to place those in the chat. We will have time at the end to go over your questions. And also, if you do have any questions you wish to maybe privately address, we'll have that information at the end as well, if there's something that you wish to disclose privately. So without further ado, I just want to introduce myself real quick. My name is Stacy Coop. I am a registered nurse, nursing home administrator by background. I've spent over 20 years in the skilled nursing facility portion, being a nursing home administrator, and recently have been working as an addictions registered nurse with persons with substance use disorders. I've also spent some time in inpatient behavioral health. So a little bit of my background before we get going. Next slide, please. So today we've got 3 quick objectives in this quick session. And first of all, we want you to understand the importance of fostering a supportive environment within your facilities for residents with opioid use disorder. We want to examine the important elements to be considered when you are creating those care plans for residents with opioid use disorder. And then third, we want to describe the steps in actually creating that person-centered care plan for those residents with opioid use disorder. Next slide, please. And first of all, we'll go over the beloved regulations, because as you know, nursing homes are one of the most highly regulated industries within our country. I've often heard statistically next to nuclear power with the amount of regulations that we need to be in compliance with, not only with federal and state, but we also have some of the others like OSHA and so forth. So next slide, please. The one that pertains to this particular session is the FTAG 740. And this is federal regulation 483.4, dealing with behavioral health services. And I'm not going to read it verbatim for you, but basically the underlying statement is that every resident in your facility, we need to make sure that they are individualized and provide that behavioral health support, meeting their physical, mental, emotional, and psychosocial needs. Each person is different or not. There's no cookie cutter for this. We need to actually look at each individual and what that means to them. Are we meeting their needs? Are we meeting them where they're at? Next slide, please. So that also encompasses our substance use disorders and individuals with that. So in that approach, as I just stated, we're going to look at every individual as their own person. Next slide, please. So just giving you a little statistics before we kind of look at that care plan aspect. Right now, statistically, more than 20% of patients older than 60 have neurological or mental disorders. Okay, so looking at that statistic, being in, of course, in our environment, dementia and depression are encapsulated in that, and then also anxiety and, of course, substance abuse. So that statistically, if you look at your population, probably 1 in 5, we need to address some sort of mental health disorder, and oftentimes the substance use goes along with that. So sometimes it's easy, or the best practice would be to look at your facility. And I know you're all working on your facility assessments right now with the August 8th due date for the new regulation going into effect. So as you're looking at those, it would be a good practice to take a look at your do a behavioral assessment as well. So perhaps take a look at the diagnoses, do a search on your electronic records by diagnosis, and then also interact with social services and see where they are at, maybe to capture some of that history if there is any substance or opioid use within that. And then specifically MDS item 15700-16100 specifically addresses actually that what I just spoke about in relation to taking a look at your assessing for behaviors. All right, so when we get a new admission, not only does it have to be person-centered, but we have to develop that care plan within 48 hours of that resident being admitted into our facility. So we need to, and I'm sure you have a template at your facility, but we need to look at the initial goals within that 48 hours, physician orders, dietary orders, therapy services, social services, and the passer is recommended if it is applicable in those situations. So those are just minimums, limited to minimum. So as that person comes into your facility, we need to start thinking on that. All right, so next slide, please. All right. So then as we move forward, we start to develop that comprehensive care plan. And these are just, again, there might be others, but some of the main areas of focus with every resident is medication and treatment. And then do they have opioid or areas to address potential opioid overdose? Do you have a plan, or do you use naloxone? Counseling and support groups. So what I would recommend initially, after after you've done the initial 48-hour plan, there are some screening tools out there to help you with this process. There is the depression scale, the patient health questionnaire, the PHQ-9, there's geriatric depression and anxiety scales. Michigan has an awesome screening tool called the Michigan Alcohol Screening Test that can be used for alcohol disorders. And then also there's other substance abuse disorder screening tools out there. And it's recommended not only for someone you might suspect, but make this a standard practice, make it consistent that you are doing that screening on all of them to, based when you're developing that care plan. You're also going to want to look at counseling and support groups if someone has identified with having some sort of substance use disorder, including opioids. Are they currently in a treatment program? Have they had previous treatment in that area? And that's also going to kind of, on a nursing level, that's going to be important because they are more at a risk for overdose if they take opioids again. It makes them more prone to that because their tolerance level is down. Nutrition, we're going to want to look at aspects of that. Pain alternatives, activities of interest, and some positive social support relationships. So just briefly going over those, I'll get more in depth, but those are some of the things that we want to make sure that we're addressing right away. Next slide, please. All right, so now that we've kind of looked at where we're going and the path to developing this care plan, we are going to take it all in and work with our interdisciplinary team and go forward. Next slide, please. So some of the considerations for these care plans, again, I'll state it again, no cookie cutter approach. We want this to be person-centered. I know the surveyors have been looking at this. So, while it might be beneficial to have a template with bullet points to consider, there's not a one size fits all. And we have seen some citations in that area where people are basically kind of copying and pasting. So it's very, very important that you just determine the resident as an individual and it is made catered to them. So one of the most important aspects that sometimes is overlooked is we want to determine what that resident wants to be identified as or with and addressed. And be transparent about that. I would make that the first question. How do you identify? She, he, etc. And what would you like to be called? Their given name might not be what they wish to be called. It's very important to them. There may be triggers with some of those things that, sometimes we're not aware of. So we want to make sure that we are meeting them where they're at and addressing them as they wish to be addressed. We want to build some transparency and honesty with them, because with that trust, you will have a better rapport and relationship and better be able to develop that care plan. You want to accept them where they're at, understand. And then, as always, create awareness that we all have those stigmas and that it can impact how we look at people and how we provide care and delivery to them. So it's important that we assess our own stigma and thoughts. Do you truly believe that this is a disease just like diabetes and so forth, and you're not having that stigma that of otherwise? So that can make a big difference, and they can pick up on that. Quite honestly, they can pick up on just even your body language, your verbal cues. Be alert to their changes of condition, and we'll go more into that in that nursing aspect in a little bit. And encourage and support the residents that are in recovery and therapy. They might come to you actively in recovery and in therapy. So we need to meet them where they're at as well and make sure that we continue those services for them to the best extent possible. We need to include, again, our non-pharmacological and pharmacological interventions. And then again, person-centered language. So don't label them. They are a person, address them how they would like to be addressed. And then we also need to understand that there also is a connection between trauma and opioid use disorder. So not only do you maybe perhaps want to use that initial screening tool for substance abuse, but also I would highly recommend trauma as well. Many of these folks have been through some trauma in their lives that precipitates, and it all comes together in who they are. So use empathy. All right, next slide, please. We did speak a little bit about stigma already, and just making sure that we're aware of our own attitudes and our policies and practices within our facility. So just there are some, there's a link right there with Superior Health Quality Alliance has an excellent series on shining the light on stigma and signing that oath that you are going to not stigmatize these individuals. All right, next slide, please. All right, and just going over a little bit, and some of this has been mentioned in the prior in webinars, but basically just again addressing that stigma can actually create more harm when we are caring for these individuals, and the slide goes over how care can actually be hindered, and we're not giving them the quality care that they deserve. So it might even actually precipitate using substances again, due to the feelings of shame. Next slide, please. We need to also make sure we understand that our language matters. We need to understand the words we use. So we don't want to use the word addict. We want to use someone, or they have a previous substance use disorder. So we need to really make sure, because those can be triggers for these individuals. So make sure that we know, and our staff knows, that our language really matters, how we talk to these people. Next slide, please. So going into the care planning, we go into the nursing process. Go into that. We first, of course, we assess, and then we plan. And then there again, we want to try and get as much information in that plan from the family, the individual. And in that planning stage, so now we've done all the assessments, we've gathered all of our information. We want to actually, sometimes it's good to just sit down, if that resident is able and verbal, to sit down with them and determine their goals and needs with them, making them aware of them. If you feel this person might have some suicidal tendencies, I've seen places have a suicide contract as well, that both people go over and talk about, the possibility, and they sign a pact with you that they're not going to do that, and they'll come to you for support. So that is something we do need to plan. There have been suicides in our nursing homes that surveyors have come, have stated and told us about, and it is it's very concerning, because it's our job to keep these individuals safe when they are within our facilities and our care. So just consider everything in your plan. So basically, it's a lot of getting to know that person. Have they had past trauma, violence? What is their history? And social services actually is very helpful. Your social services department, even your CNAs, your direct caregivers that talk to this individual, they could benefit you in making this plan for this individual. Next slide, please. All right, so our next step is, what interventions are we going to take? Again, we want to next slide, please. Sorry. All right. So what interventions are we going to take with this individual? I've listed some on this slide for you, but it's very, very important that we identify what triggers that this resident could be susceptible to. For example, was the individual in World War II? If they hear something loudly drop, or that sounds like gunshots, is this going to put them into a situation? If not, that's why it's so important that we gather this information and know them well, because what might just be a loud noise to you might not be in other cases. And that's just one example. Even touching, some individuals might have had some trauma with rape in the past, just an example, and don't like to be touched, or need to be, you need to talk them through those cares as you are touching them, because they have faced that trauma in the past. I know it sounds simple, but yet it's not. It's not. It's about knowing that individual and knowing where they're at and just understanding that this could precipitate factors in their care. And then again, we've got the options of if we talked about recovery support. Peer-led support groups are really huge and up and coming. If you can get those into your facility, those are amazing. You're going to be hearing more and more to come. It's a big government initiative with the peer-led support and peer leaders. And then also activities, and that can help, just the calming effects that can help as an intervention. So it's something to look at. And then also if they do have, possible substance order past disorders, do you have an order that they can have naloxone as needed if you would recognize someone is overdosing? And believe it or not, the state of Wisconsin actually just had a case of someone overdosing in a nursing home. The opioids were brought in by family members for this patient. And so it is important that that is addressed, and maybe a standing order on that resident's chart. And then also, could they take buprenorphine, otherwise known, or Suboxone? Next slide, please. And then, of course, we always want to evaluate. Is what we have done, are the interventions that we have come up with, are they effective? Do we need, to evaluate this? And make changes. So evaluate this as needed, at least quarterly. We need to follow up if it's not working. We need to assess, right, nurses? And then utilize that interdisciplinary team. And then resident family input. Sometimes those are huge things, especially, if the resident's nonverbal, so forth, or maybe they don't want to tell you something that would be, that if you knew, you'd be like, oh, okay, that's why they are not partaking in activities. Okay, this is, it might give you some of that background information. And then again, we've got to modify the care plan as needed. So I like to look at the acronym when I'm doing this, the CARES acronym, and it's connect, assess the behavior, respond appropriately, evaluate what's working, and then share that with others. Next slide, please. All right. So we also want to look at effectiveness measures too. So make sure some of those things that we could look at in evaluation are the symptoms decreasing by what is in place? Do they have an improved health status? And are they satisfied with the care that's delivered? Just a simple satisfaction rating. So Superior Health Quality Alliance has developed a substance use disordered person-centered care plan example, and that you're seeing that on your screen right now. And this is available to you, but these are just some ideas. So again, we're using person-centered language. Just an example would be, I've maintained periods of recovery in the past, and then a goal for that, and interventions, and who is going to help with that. So this is one example. I also found there's a website called Nurse Labs, and it has a lot of example of nursing care plans and interventions. So that you can find online as well, and that can be helpful with developing some of these care plans. So in summary, appreciate the work that everyone's doing. We're seeing more and more of persons with substance use disorder entering our facilities, whether we know it or not. So it's important that we have some of these strategies in place. Like I said, screening everyone consistently can kind of maybe make some of those determinations. And then meeting them where they're at. What's best for them, knowing them. And then, even though I know we're probably all doing it, making sure it's all documented in the care plan. Because a lot of times facilities are they're doing it. They have the practice in place, they have the possible intervention in place, but it's not documented for paper compliance. This was a short overall I guess, brief introduction to care planning for those with substance use disorder. Are there any questions of me? Otherwise, feel free to put those in the chat. Otherwise, next slide, please. My contact information is listed here. Feel free to email me. And we can discuss. I can set up a meeting with you if you need other resources. And then the slides have been posted in the chat. And next slide, please. And these resources are listed, the Superior Health Quality Alliance resources, as well as the minimum data set, where you can obtain some of that information for your assessment process when you're looking at that facility assessment and what behaviors you have, and maybe, when you're looking at the culture of the facility as a whole, you can pull some of that data from that assessment. Okay. Any other questions? All right. And then again, our series will be posted. The first 3 are posted already. This one will be posted within the next week or so. And again, feel free to contact me if you have any questions, if you need any support. We are hearing this is something the surveyors are looking at, and making sure that we are addressing those care needs of those individuals. And I don't think it's going away anytime soon, just looking at our population up and coming and the numbers of substance use disorders out there. So it is something we need to think about and manage within our facilities. Thank you for joining us again, and have a wonderful, wonderful afternoon.